Hi, welcome again to another edition of Matters of the Heart, brought to you by Haverhill Community Television and Pentucket Medical Associates. I'm Seth Bilazarian, a cardiologist with PMA, and I'm here with my associate, Dr. Emily DeLude, a nephrologist or kidney specialist in the treatment of medical diseases of the kidney. And Dr. DeLude is joining us today to discuss a common problem that nephrologists or kidney specialists address and evaluate called hematuria. And hematuria is a fancy doctor word for blood in the urine. Heme is blood and urea is, of course, urine. So hematuria is blood in the urine. And I asked Dr. DeLude to join us to talk about this today, about what that means, what the significance of it is, to answer some questions about how it might be evaluated, and what kind of treatment there might be available for it. So since this is an area not in my expertise, I'm going to turn it over to Dr. DeLude to tell us more about hematuria.
Okay, thanks, Seth. So hematuria, as Dr. Bilazarian mentioned, is blood in the urine. And there are a couple of different types that we generally categorize the hematuria into. The first would be blood that you can see, visible blood in the urine. And the second would be blood that is really not visible with the naked eye. It's called microscopic hematuria. And this is generally detected in the doctor's office, for example. There are different causes for each of these different types of blood in the urine that I'd like to discuss a little further. Why don't we just start with the visible blood in the urine,
Okay.
what we, as physicians, sometimes call gross hematuria, which is
It doesn't mean
descriptive.
it doesn't mean it's vulgar. It just means that it's a lot.
It's a lot.
Being a big one.
Yeah.
Okay.
Well, the interesting thing is that it really doesn't take much blood to get into the urine before the human eye can detect it. About a milliliter,
About a drop.
a drop
Yes.
of blood in the urine in a liter of urine, say a quart of urine, can actually be detected as visible discoloration of the urine.
Okay.
So it's pretty amazing how we're able to actually see that change, usually pink or red in the urine. So when someone has this discoloration in the urine, obviously it's a little bit alarming because we're not used to seeing our urine looking pink or red. It usually is either light yellow or dark yellow. One thing I did want to say is that I do have some patients who get concerned sometimes that their urine is discolored, because I'm telling them, let me know if you notice discoloration in your urine. And they'll say when they first wake up in the morning that their urine appears dark. And that's actually pretty normal. And as we sleep and we're not drinking during the night, our urine tends to become darker in color. It's just dark yellow generally. And then as we drink throughout the day, the urine becomes lighter yellow. And that's pretty normal. That would not be something that I'd necessarily be concerned about. But what does become concerning is when the urine starts to look pink or red. And even more concerning is when it starts to look a little bit brown. Some people would call that root beer kind of color or Coca-Cola colored urine. And none of those things are really normal per se, and that would be something that you definitely want to seek medical attention for. There are, however, some different colors in the urine that may actually be okay. And I'd just like to say that some people might notice if they eat a lot of beets that their urine can turn kind of purplish almost, kind of pinkish. And that's actually called beeturia, because there's certain pigment in the beet that causes the urine to look a little like a beet. You'd have to eat a lot of beets for that to happen. But that would be a situation where, we'd evaluate it, but not necessarily something that's a disease.
And I'm guessing I would know the treatment for beeturia.
What would that be?
I would say either nothing or stop eating beets, I'm guessing would be the answer.
Exactly. It's not dangerous. And the pigment in the beet is not damaging the kidneys or the bladder in any way. And then the other kind of common discoloration of the urine that we sometimes see is from a medication that's used to treat pain in the bladder when there's urine infection. And that's called pyridium. And that sometimes turns the urine kind of an orangish, reddish color. It's pretty distinctive. So that would be something that I try to warn patients about ahead of time, that you're going to notice your urine is going to look a little funny as a result of that medication.
Okay.
But beyond that, if the urine does look a different color and it is due to blood, there are a lot of different reasons for it. Generally speaking, if it's more of a pink or of a red color, that does tend to be consistent with blood that's getting into the urine. And as a nephrologist, my job is to really try to figure out, well, where is it coming from? You know? And generally, if there are clots that you can see in the urine, blood clots, that usually indicates that the blood could be coming, say, from the bladder itself, and generally not from the kidneys. And that would have to be evaluated quickly, because sometimes you can have tumors, for example, in the bladder, and they can bleed. If you're taking Coumadin, a blood thinner, and you notice blood in the urine, you can't just dismiss it and say, oh, well, I'm taking a blood thinner. That's not necessarily normal. It would be a concern that maybe your Coumadin level's too high, and you'd have to really, you know, I would seek attention right away to make sure that the Coumadin level is not overshot its mark. But you'd still really want to be evaluated for why you have blood in the urine. So generally speaking, for the adult population over the age of about 40 or 50, when we see blood in the urine, the first thing that we have to evaluate is, you know, could there be some kind of malignancy, some kind of cancer that's either in the bladder or in the kidneys. That's generally our first concern of, you know, the most heightened concern for us. But more commonly, it's not. More commonly, it's related to infections in the bladder. And when there's irritation in the bladder lining or inflammation due to infection, you can actually see blood in the urine as a result of that. That's a bit more common of a scenario. But usually in that situation, you'll have symptoms. You'll have maybe burning when you urinate, or you'll be urinating very frequently. You may have a low-grade fever. You're not feeling well. And in that situation, we can do a urine culture, and we can check for a bacteria in the urine.
You mentioned earlier, so you've just been reviewing for us that term you said was gross hematuria, where you can actually see your blood is tinged or frankly bloody. And then, but earlier you also mentioned this thing called microscopic hematuria, where there's actually blood in there, but you can't see it. So less than a drop per quart. How does that get detected? How does a doctor evaluate that and figure out that there is microscopic hematuria?
Sure. So in the office, the doctor will do what's called a urinalysis, or sometimes a urine dipstick. And that's just when a urine sample is collected, and the urine is checked for multiple components, and blood is among them. This is generally done on screening examinations, although it's not actually recommended by the Preventive Task Force to do screening urinalyses, because the yield is not so high, and generally it's benign. But in individuals who there's a concern that the urinalysis may be abnormal, for example, if there's risk factors, for example, for kidney disease or cancer, then it's no longer routine screening, and we do recommend that urinalyses be done. And these would include some things like diabetes, heart disease, high blood pressure. A family history of kidney disease would also fit into that category. And also a family history of kidney cancers, or a personal history of some type of kidney or bladder cancer. Those would be indications that the urine should be examined in the office for the urinalysis.
For the purposes of our audience, could we just take a pause? And you've been talking about some important things, but just for purposes of review, could we review what we're talking about? Because sometimes patients are confused about what's the kidney, what's the bladder, and then there's connections between them. So maybe you can start at the top of the system, the kidneys, and end sort of down at the bottom.
That's a great idea. So yeah, starting at the top, we have the two kidneys. They kind of sit up in the back, up back here in the back of your body. And then the urine comes out of the kidneys through what are called the ureters. And these are a tube from each kidney that leads down into the bladder.
So if I could just pause, so the kidneys really are the thing that is making the urine. They're filtering the blood, and they actually make the urine, and the urine comes out of the kidney to begin the process of the urine making.
Exactly.
Okay.
Yeah. And then the urine then enters into the bladder, and from there into the urethra.
Okay.
And then it exits the body.
Okay, so kidneys, ureter, bladder, and then urethra. That's the system that we're talking about. And when we've been talking about bleeding, it could be any one of these that could be a problem, but you told us that some are more likely to be the bladder, for instance, which sits very down low near the place where the urine comes out.
Exactly.
Okay.
Yeah. So, right, so looking at any of those places, we have to try to, by the process of elimination, figure out where that blood could be coming from.
Okay.
Exactly, yeah. So this microscopic hematuria is really detected, even though it can't be seen, when the doctor does a urine dipstick or the doctor does a urine dipstick or a urinalysis in the doctor's office. And that's a very, very sensitive test. And in fact, that test can really pick up only 1 or 2 red blood cells in a specimen. So it's very sensitive to pick up small amounts of blood. So the problem may be with that, it's maybe picking up things that may be insignificant, but regardless, it picks up very, very tiny amounts of red blood cells.
Is there a limit at which you would be just totally dismissive that it's so few it doesn't matter, or is any an important amount?
Well, generally speaking, more than 2 red blood cells per the field of vision under the microscope is considered abnormal blood. But we really, that's a good point, we really don't know. Any amount of blood is not necessarily normal. It shouldn't necessarily be in the urine itself. Yeah. So the microscopic examination will show us if there is blood in there. It'll also show if there are other things too, like protein or cells, like white blood cells, which is a different type of blood cell that could be in there as well. And sometimes that can indicate infection, for example, as well. So generally speaking, when those red blood cells are detected in the urine, it should be repeated, because it may just be a spurious finding, and if there are only 1 or 2, it may not mean anything.
Just a bad day for the kidneys.
Maybe, yeah. The other thing to be aware of is that women, if they're menstruating, some of that blood from the vaginal tract can actually cross-contaminate the urine sample. So generally speaking, if a woman is menstruating, she should come back to repeat the sample when she doesn't have her period to check for blood again. Yeah.
You gave some reasons why someone might have the gross hematuria. You mentioned infection and, of course, concerning things like cancer, and it could be coming from the bladder, the kidney, or one of the other parts of this kidney system, urinary system. What are the causes of this microscopic hematuria? Is it the same thing, just in lower quantities, or are there other causes of microscopic hematuria?
Yeah, sure. So there can be a lot of different reasons for the microscopic hematuria as well. Certainly, again, if there are risk factors for any type of cancer of the genitourinary tract, and that's anywhere from the urethra, the bladder, the ureters, and up to the kidneys, then that should be evaluated much more, seriously. Those risk factors do include age, so advanced, not really advanced, but age over 40 or 50 is generally considered you'd be at more risk than, say, if you were a child or in your 20s or 30s. If you're a smoker, smoking is a risk factor for cancers of the genitourinary tract as well, and any family history of cancers as well. Some exposures to organic chemicals in the workplace can put you at risk for bladder cancer too. So if you fall into that category, or if your age is advanced, it is recommended that even small amounts of blood should be evaluated further. And generally speaking, it should be repeated to confirm it. And if it's still there in abnormal amounts, then it should be evaluated with a urine culture just to make sure there's no infection hiding in there. If that comes out okay, then we start thinking about doing x-rays to look at the
all right, so tell us about that. So you just to summarize, what I think you said is that perhaps a patient's primary care physician has identified blood in the urine, either the gross or microscopic type. You, I think, described that it's important to take a history to see if the patient's at risk, smoking, occupational exposures. And then you said a culture would be done to evaluate if there's an infection, because that could be a sort of an easy explanation. Then take it from there. What might be done after that if it does not identify an infection? What are the next steps? You mentioned x-rays. What kind of x-rays might be done?
So generally speaking, a very sensitive one would be a CAT scan or a CT scan. And this can really look very closely at your kidneys and your ureters, your bladder. This would identify any masses. Also can look for kidney stones, because kidney stones can also be causing blood in the urine. And it can look for tumors as well. So that would be a study that probably would be done, especially if you're in the risk factor range for any type of problems with potential cancers of the genitourinary tract.
Would that be normally a first test, the CAT scan, or there's some other kind of testing that might be done first?
Sometimes you could just do a simple X-ray, which could look at kidney stones, or an ultrasound examination. But if there's a real concern, those studies just really aren't as good. They're not as sensitive for looking for these things. So if those were all negative, you would end up doing the scan anyways.
Okay.
So a lot of folks choose that as the first study because it's really the best. Yeah.
Okay.
If that's all negative, then generally you'd be referred to a urologist at that point.
So what's a urologist? You're a nephrologist. What's a urologist?
So I don't know if they'd appreciate this, but I generally think of the urologists more like the plumbers, and I'm more the chemist. So the urologists do surgery, and they're really involved in the structural defects in the genitourinary system as well. And what they can do is a procedure called a cystoscopy. It's a camera and a tube that goes up through the urethra and into the bladder, and can look to see if there's anything in the bladder or even the beginnings of the ureters that are contributing to blood in the urine.
So you mentioned that at this point in the patient's evaluation, as we've been walking through it, the patient already had a CAT scan. So the CAT scan would not be able to see a bladder cancer, for instance? I just want to just confirm that that's what you're saying.
If it's small, no. If it's a big one, it's a large tumor, yeah. But if it's small and it's in the wall of the bladder, it often can be missed.
Okay, so these are very, very tiny, almost like a mushroom, but tiny mushrooms growing on the inside of the bladder wall, and can just be identified by looking at it directly.
That's right.
And that's what the urologist would do.
Exactly.
Okay.
Yeah. So if that comes out negative, and so this evaluation so far really hasn't yielded anything, then it's reassuring, for one thing, because we've ruled out any really bad, malignancies, cancers, kidney stones, for example. So that's, you should breathe a sigh of relief, but it doesn't really explain why the blood is still there. And usually at this point, the patient is referred to see me, a nephrologist, at that point. And then I can do further evaluations to really figure out, why the blood is still in the urine.
Can you help me understand, just in a very vague, general way, what percentage of patients who have hematuria have these different problems? Are about half of them infection? Do you have any sense about that, just from a ballpark standpoint?
I don't know about exact numbers, but a lot of it does depend on age. So for example, if you're a child, generally speaking, cancers are very low on the list, because your cells are very young and vital, and they don't generally have cancers of the genitourinary system that early. So in those cases, it's generally more what we would call transient or benign hematuria, where it comes and goes, but it doesn't really amount to much and generally goes away. So it's reassuring for parents to know that. Also, it could be infections. So children can get urinary infections, and that would be something that would be readily treatable. Yeah. As you get older...
So the old people you describe, over 40.
Over 40, yeah.
Yes.
Not old. But over 40 as you age, then certainly your risk for malignancies, for cancers, starts to increase. So definitely we start thinking about those. But certainly you can still have infections. You can still have kidney stones, for example. And then...
Would infections be a majority? And then like a quarter stone, and then a few, or more than that? How would those break down approximately?
Sure. I mean, general infections, yeah, would probably be the bulk of the hematuria cases, with cancers being a much smaller minority. Yeah, and kidney stones probably in between.
Okay.
In between there, and again, depending on your symptoms, kidney stones generally, if they're trying to pass, are painful, but you can have kidney stones that are in the kidneys that may not be causing any symptoms, but can cause some blood in the urine. So
and what's the incidence of that? Just these are all questions that I have, and I'm not being a specialist like you.
Yeah.
How often are kidney stones identified just as a matter of incidence on a CAT scan? How many are identified through blood, and how many identified through the worst pain of your life kind of thing? How would that break down?
Well, I'm not so sure about the exact statistics of that. Kidney stones themselves, they have myriad causes. And there are some diseases that predispose you to them, and where the incidence is very, very high. But generally speaking, there is a small percentage of people who may never form a stone, but they have blood in their urine because of calcium levels and crystals in their urine that are causing irritation. So they actually don't even need to have a stone, but they'll have little crystals of calcium causing blood in the urine all the time. So that would be something to consider. But generally speaking, yeah, when a stone tries to pass, you know it. It's very, very painful, yeah. So as far as other causes go, we'll talk a little bit more maybe about the nephrologist, my role. So really my role is to try to figure out, it's been ruled out that there's any obvious problem sitting in the bladder or in the urethra or in the ureters. That kind of brings us up to the kidneys now, which is, that's my specialty. So that's what I'm trying to figure out. So as far as that's concerned, a very useful test that the nephrologist brings to the table is something called a urine sediment examination. And that really involves taking the urine and putting it in a test tube and spinning it at very high speeds in a centrifuge machine. And at the bottom of the tube is a little, what we call a sediment, and that can be examined under the microscope. And if there are blood cells in there, I can help determine if those blood cells just look like normal, healthy blood cells, or if they look what we would call atypical or dysmorphic, and they look what perhaps coming from the kidneys themselves. And those have a pretty characteristic appearance. They're called acanthocytes, and they look different because they've tried to squeeze through the small blood vessels in the kidney, and when that happens, they get damaged. Yeah. When I see these blood cells, I start thinking that there's a potential kidney disease underlying, what we would call a glomerular kidney disease. I can talk a little bit about the glomeruli, if you'd like, just to shed some light on that. But the kidneys are made up of millions of filtering units called glomeruli, and each glomerulus has a bundle of little capillary, little tiny blood vessels. And these blood vessels take the blood from the body and essentially clean it and then turn it into urine. So they're pretty amazing blood vessels in that way. Generally speaking, all the blood that is filtered through those little capillaries, it's like a little network of capillaries, is cleaned, and it should not leak any blood into the urine. But when blood does leak into the urine, that's abnormal. And I see that in the urine sediment as these unusual-looking red blood cells.
So these glomeruli, as you described, those small filtering units, you can tell by looking at the urine, or what you said, the sediment of the urine, and know whether they're sick.
That's
but
right.
What are the causes of this sickness? Is that infection or other causes?
So generally speaking, it's a kidney disease, and whether that starts in the kidney or starts from other causes that may cause secondary kidney disease is really what we need to figure out. But generally, not infection. Infection doesn't necessarily itself cause these changes. There are a lot of different diseases we can talk about in a bit that will cause this type of blood to leak into the urine. But it's concerning because what it means is that there is a disease of the kidneys present, and that needs to be worked out further. Yeah.
So tell us, in our last several minutes, what kind of briefly evaluation might lead to a diagnosis? What patient is now been told there's something wrong with my kidney?
Sure.
What am I going to do to figure out what this is and then form a treatment plan?
Sure. So depending on how much blood there is in the urine, that can also give some clues. If it's a large amount of blood that's there, we tend to think a little bit more about some other disease processes, some types of family diseases. And if there's any history of a family kidney disease, we start thinking about something called hereditary nephritis. And that's where the blood tends to leak into the urine inappropriately. And that it can actually lead to other problems too with the ears and with the eyes. So some folks go deaf very early in life and have blindness or what we call ocular abnormalities very early in life as well. So if anybody gives me that family history, that heightens, my awareness that there could be a family-related kidney disease here. The thing that really concerns me is if there's not just blood, but if there's protein that leaks into the urine, because that's even more concerning, that the kidney disease is more serious. Yeah.
And then, so once you identified the protein and these abnormalities in the urine sediment you described, what are other tests that might be done for evaluation?
Sure. So we can measure the amount of protein in the urine to evaluate that. We can do other tests that look for other causes of the kidney disease that we might glean from the history. For example, certain diseases like lupus can cause kidney disease, and there are certain manifestations of that people will present as that would be concerning to us. If it happens that you only bleed when you have an infection, let's say you have a bad cold, that makes us concerned for something called IgA nephropathy. Or if it happened after you were sick with the strep throat, for example, a few weeks ago, we think of something called a post-infectious nephritis, and that generally will tend to resolve. But if there looks like there's something significant and severe, we can do a biopsy of the kidney, and that'll tell us really, for sure, exactly what's going on in the tissue of the kidney.
And in that way, actually look at those glomeruli, those filtering units you described, and have an identification of what the problem is with them.
Exactly.
Okay, great. Well, I wanted to just take obviously a lot of topics we've covered today on the topic of hematuria, about its evaluation and its ultimate diagnostic approach. I want to just give you a few minutes for the last word on this topic. Any suggestions you might have for members of our audience to think about before we close?
Sure, great. So just as take-home points, blood in the urine can be either visible or microscopic. Generally speaking, both require further evaluation by your doctor. If it's something that comes and goes, we have to think about infections. Also, we have to worry about, if you're a bit older and have other risk factors, that there could be some type of cancer present, and you need to have an evaluation for that very quickly. If it's something that's very minute and is not there all the time and goes away, it may mean nothing, but you'd still need to see your doctor regularly to determine if that blood has disappeared or if it's still present.
Great. Well, thank you, Dr. Emily DeLude, who joined us today on Matters of the Heart here on Haverhill Community Television. She covered the topic of hematuria, a really big topic, and did a great job condensing it into a short review for our audience. Until next time, I'm Seth Belazarian. Thanks for joining us here on Haverhill Community Television. Good night.